Good morning to you all. Today's topic is on interdisciplinary periodontics and a short note on recent advances in periodontics. Learning outcomes are the role of periodontists in various interdisciplinary procedures, the effectiveness of periodontal therapy during orthodontic treatment, the role of periodontist in prosthodontics treatment sequence, the periodontal treatment outcome in endoperio lesions, three possible interrelationship treatment possibilities. Interdisciplinary periodontics. What is interdisciplinary? When two or more departments, when they work together to create a greater effect than that they predicted by knowing only the separate effects of individual agents, which involves the combining of two or more academic disciplines into one activity by crossing boundaries and thinking across them. The rationale. Periodontal health is a prerequisite which forms the foundation of a successful comprehensive dentistry. The therapeutic goals of patient comfort, function, aesthetics, predictability, longevity, and ease of restorative and maintenance care are attainable only by a careful, constructed interdisciplinary approach and accurate diagnosis and comprehensive treatment planning, which forms the cornerstones for the success of a comprehensive dentistry. Sequence of treatment in preparing periodontium for interdisciplinary dentistry. It has been classified into two. First comes the control of active disease and then comes the pre-prosthetic surgeries. Under control of active disease, emergency treatment that is mainly done to alleviate symptoms and stabilizes the acute infections. Extraction of hopeless teeth. Retention of hopeless teeth sometimes result in bone loss around the adjacent teeth, so it has to be extracted. Oral hygiene instructions. Proper oral hygiene measures are needed to control the active disease. Scaling and root planing. Proper method of scaling and root planing is needed. It will reduce the further progression of disease. Then re-evaluation. The gingival tissues are evaluated to determine the oral hygiene adequacy, which permits the sufficient time for the control of disease. Then comes the periodontal surgery. If it is not subsided by the phase 1 therapy, it moves on to periodontal surgery. So it should be done along with the replacement of missing teeth either by implants or by dentures. Then comes adjunctive orthodontic therapy. Orthodontic treatment has been shown to be an adjunct. It has shown to be successful as an adjunct to periodontal therapy. It should be done only after the active disease has been controlled. So any failure to control this active disease, active periodontitis, it may result in acute infections or bone loss during tooth movement. Pre-prosthetic surgeries. Under that, management of mucogingival problems, preservation of ridge morphology after tooth extraction, crown lengthening procedures, alveolar bone reconstruction. Management of mucogingival problems. These mucogingival problems, they are usually associated with aberrant frenum, decreased vestibular depth, and also decreased attached gingiva. So this is the case where it is indicated for the RPD. So here we can see there is decreased attached gingiva in relation to the canine. So it has been advised for the soft tissue grafting where we can place this free gingival graft. So the first the case that is done with soft tissue grafting, and the second picture it shows there is abundant attached gingiva and vestibular depth. Preservation of ridge morphology after tooth extraction. Alveolar ridge resorption is a common sequence of tooth loss. So we need to preserve the ridge after extraction. So this is the case where the tooth is automatically removed from the socket and the socket has been debrided and the graft has been placed in an effort to reduce this ridge collapse. So this then next the provisional this denture has been placed, there is ovate pondic temporary ovate has been placed, pondic has been placed, and then with the regaining this gingival architecture and the papillary architecture you can see in this picture. So then finally an aesthetic processes has been given and this is the final restoration. Next comes crown lengthening procedures. They are mainly done to provide the retention form, especially for impression taking and for the restorative margins and for tooth preparation and for the placement of prosthesis. So this is the procedure that is which includes the removal of soft tissue, either soft tissue or both soft tissue and bone. So reduction of soft tissue alone, which is indicated if there is adequate attached gingiva and more than 3 mm of tissue coronal to the bone crest. The important point is that it should be done in a manner that the biological wood should be preserved. What is biological wood? What is the importance of biological wood? So this is defined as the physiological dimension of the junctional epithelium and connective tissue attachment. So any violation in the biological width, it leads to the maintenance of the biological width, that is by increased inflammation, and there will be inflammatory response, and thereby the bone loss, and this biological width will be maintained after it. So this is found to be constant, approximately 2 mm. This is the picture which shows the biological width, that is junctional epithelium and the connective tissue attachment. They togetherly constitutes this biological width, and the gingival sulcus of 0.69 mm. So the placement of the restorative margin is usually 0.5 mm to the sulcus if there is a sulcus depth of 1 mm, and that is for the maintenance of the biological width. So how we can correct if it is violated, how we can correct, that is by surgically, or to avoid violation, how we can maintain this biological wood, that is mainly surgically removing bone away from the proximity to the restorative margin, and second by orthodontically extruding the teeth and thus moving the margin away from the bone. So why do we need to do this orthodontically extrusion? So when it's in the aesthetic areas, especially in the maxillary anteriors, when they follow the same gingival margin pattern, we cannot go for the surgical removal of bone or soft tissue. So in order to maintain the aesthetics, we have to go for orthodontic extrusion of the tooth, and thereby we can maintain the biological width. So here there is the soft tissue is greater than 3 mm. So this crown lengthening is indicated. So that is by the gingivectomy can be done to attain the crown lengthening. So here whereas less than 3 mm of soft tissue between the bone and gingival margin, so we need to go for a flat procedure, and also recontouring can be done for crown lengthening. Restorative interrelationships, biological considerations, aesthetic tissue management, occlusal considerations, and special restorative considerations. Under biological considerations, margin placement and biological width evaluation, correcting biological width violations, margin placement guidelines, clinical procedures in margin placement, tissue retraction, provisional restorations, marginal fit, crown contour, subgingival debris, hypersensitivity to dental materials. Under aesthetic tissue considerations like managing interproximal embrasures, correcting open gingival embrasures, managing gingival embrasure formed for patients with gingival recession, phonic design, then occlusal considerations, any high points. If it is there, you have to go for occlusal therapy. That is, then comes the special restorative considerations, root resected teeth, splinting, anterior aesthetic surgeries. Margin placement guidelines. As we said before, the base of the sulcus is the top of the attachment. So ensure that the margin is placed in the sulcus and not in the attachment. So for a proper placement of the restoration, we need a 1 mm of sulcus, 1 to 1.5 mm of sulcus, so that we can place the restorative margin 1.5 mm below the gingival tissue crust. So if it is more than that, you can place the half the depth of the sulcus below the tissue crust. Okay, if it is more than 2 mm, this probing depth, then again it leads to increased plaque retention, again the inflammatory response, and which leads to the decreased periodontal health maintenance. So this gingivectomy should be performed to lengthen the teeth, and we can create a 1.5 mm sulcus and go for 0.5 mm below the gingival tissue crust placement of restorative margins. Alveolar ridge reconstructions. That, as we said before, patients are frequently seen with alveolar ridge resorption after tooth loss. It can either occur by vertical loss or can be horizontal, buccolingual, epicocoronally. That is what we said. That is, it should be reconstructed. That is, to provide adequate anatomical dimensions for the construction of an aesthetic pontic, and also for aesthetic purposes we need to reconstruct it. So for small defects, it may be treated with soft tissue ridge augmentation. For larger defects, we should go for hard tissue modalities. So this is the picture showing that is reconstruction, alveolar ridge reconstruction. To avoid the ridge collapse, that is mainly in the anterior areas, that is hard tissue modality has been used, that is bond block has been used. Perio-endo lesions. That is perio-endo relationship, it plays an important role to control this perio-endo lesions. The Simon has classified it into 5 main types: primary endo, primary perio, secondary endo, and combined lesion. Primary endodontic lesion, that is originally an endodontic problem with fistulization from the apex and along the root to the gingiva. So that is primary endo. So endodontic therapy is needed for it. And second one is periodontal pocket can deepen to the apex. Secondary involve the pulp, that is primary perio. So periodontal therapy is needed for this case. And the third one is long-standing periapical lesion that might drain through the periodontal ligament. So it leads to this retrograde periodontitis usually. So that is primary endo, secondary perio. For this, they need endodontic therapy as well as periodontal therapy. Then comes periodontal pocket can infect the pulp through lateral canal, which can in turn result to the periapical lesion. So this can involve this pulpal region either through the lateral canals, any accessory canals. It can be through apex, lateral canals, or through the furcation areas, interdental areas. It can reach the pulpal region, so which involves the endodontic lesion. So that is primary perio and secondary endo. Here also they need endodontic therapy followed by the periodontal therapy. Then comes the two independent lesions, that is both they occur together, that is periapical and marginal can coexist and eventually fuse with each other. That is the two combined lesion. Here also they need both treatments. Schematic illustrations demonstrating the pathways for the drainage of a periapical abscess, that is either along the periodontal ligament, that is through the sulcus, and other one extra-osseous drainage which exits either in or near the sulcus. Then comes perio-ortho interrelationship. Orthodontic treatment, that is, it is imperative that periodontal infection should be controlled before orthodontic treatment is initiated, that we need to maintain the periodontal health during orthodontic treatment, and also there are some of the defects that need to be treated before orthodontic treatment, and also after orthodontic treatment the periodontal health should be maintained for the success of the treatment. So we can just discuss about the pre-orthodontic osseous surgery, some of the treatments needed for some defects like osseous craters and three-wall bony defects. Osseous craters, that is two-wall defect. So this does not improve with orthodontic treatment, that should be eliminated by reshaping the defect and reducing the pocket depth. And then comes the three-wall bony defects. So these are amenable to pocket reduction with regenerative periodontal therapy. So the result of periodontal therapy is stable at least for 3 to 6 months after periodontal surgery. Orthodontic treatment may be initiated. Then comes perio-prosto interrelationship. During prosthodontic treatment also they need pre-prosthetic surgeries to be needed before the replacement of prostheses, and also for the pontic placement, for the aesthetic purposes, for the correction of uneven gingival margins. And next comes this removable partial denture can be used as professional denture function to distribute occlusal load and also as a temporary or provisional splint. Then comes recent advances in periodontics. So first comes materials used for regeneration. It has been classified under different procedures like root modifications, prevention of epithelial migration, bone grafting, growth factors, and soft tissue grafts. Pref gel. Pref gel is a pH neutral 24% EDTA, ethylene diamine tetraacetic acid, root surface conditioners intended for topical application onto the exposed surfaces during periodontal surgery. So, which offers an effective removal of spear layer. So, this picture shows the first one, that is the removal of plaque and calculus, that is scaling and root planing, followed by the placement of root conditioning agent and thereby rinsing with water, and after that the placement of graft and then the closure of flap. Then comes mTOCAIN. mTOCAIN is a biology-based product composed of enamel matrix proteins. It is amylogenin is the main component of mTOCAIN, and also this PGA and water. So it is available in this 0.3 ml syringe, contains about 9 milligram of amylogenin, and the 0.7 ml syringe about 21 milligram. So this derivative stimulates the regeneration of new cementum and periodontal ligament fibers on the root, resulting in the regeneration of a new attack. Then comes GEM21S, the growth factor enhanced matrix. This is a combination of bioactive protein as well as an osteoconductive matrix, that is a recombinant purified human platelet-derived growth factor and also beta tricalcium phosphate. Next comes PepGen P50, that is the first and only bone replacement material that combines organic and inorganic components. It usually this mimics the cell bonding sequence of type 1 collagen, and that mimics the bond. So that is, it accelerates the bonding of cells to the particle matrix and initiates the cascade of events which results in the formation of new bond. Then comes alloderm, a cellular dermal matrix. So it is mainly used for soft tissue grafting. It is derived from human skin, so which undergoes a multi-step operative process to remove this epidermis and cells which lead to tissue rejection. So it mainly contains collagen, elastin, vascular channels and proteins, so which then support revascularization, cell repopulation and tissue remodeling. Then comes this platelet-rich fibrin. This is very important. This is a newly material which is leading in this era, that is platelet-rich fibrin, or a modification, that is leukocyte platelet-rich fibrin. So this is a fibrin matrix. It is a second generation of platelet-rich plasma, where this autologous platelets and leukocytes are present in a complex fibrin matrix, which accelerates the soft tissue and hard tissue regeneration. So it can be used as membrane also for the prevention of epithelial migration. So it's made advantages over this PRPs: ease of preparation, minimal expense, lack of biochemical modification, and they showed a significant improvement in clinical periodontal parameters, and both in clinical parameters and also in radiographs when compared with open flap deprived. Then comes piezoelectric surgery. So that is with minimal injury. The main advantage of the piezoelectric surgical system is that it with minimal injury and maximal surgical precision. Okay, that the maximum operative visibility and the blood-free surgical state. So that is piezoelectric surgery. Then microscopic surgery. So the picture shows that how it has been evolved. That is, the microscopes have been used for the surgical purpose. Mainly it is used for periodontal plastic surgeries, as we need the precise work, that is with greater precision, making more precise incisions also with smaller instruments, so which causes less trauma and less scarring, that is least post-operative scarring complications, so which facilitates the post-operative healing, right? So it is mainly used for soft tissue augmentation procedures. So that is and more advantages, that the better view of the radicular root surface, which leads to easier this radicular root instrumentation also to remove the local factors and the correction of bony defects. The first one, biosensors, as the name indicates, it is a gadget to sense or identify, measures the compounds and natural responses by creating signals at that point where it interacts with an analyte. That is, they are currently being used to recognize some of the biomarkers, so especially for indicating the periodontal diseases. So then comes gene therapy, which uses purified preparations of a gene or a fraction of a gene to treat diseases. In periodontics, mainly that is used for platelet-derived growth factor gene delivery and bone morphogenic protein delivery. So future trends is mainly on this genetic approach to biofilm antibiotic resistance and this periodontal vaccination. The study is almost going on. So then comes a stem cell therapy and tissue engineering. That is the science of tissue engineering, aims at the repair of damaged tissues as well as creation of the replacement of the lost bone. So mainly uses this mesenchymal cells for the regeneration. That is, it gets stimulated to form osteoblasts and then the bone formation. So tissue engineering procedures that needs three key elements. That is, first one is signal for morphogenesis, that is bone morphogenic proteins and fibroblast growth factors. Then progenitor stem cells, that is the cells mainly used from bone marrow, periodontal ligament and dental pulp. Then scaffold, so that is of extracellular matrix components that mainly composed of collagen, fibronectin and proteoglycans. So there is one advancement related to the that's 3D printing micro channel fiber guiding scaffolds have been developed mainly to orient these periodontal fibers according to their directions. This will be inserted to the newly formed bone and cementum. Coming to the future trends, nanotechnology, artificial intelligence, 3D printing and microdentistry. Then comes the last one, that is nanotechnology, which uses nanomaterial. That is, these materials are materials with components less than 100 nanometer in at least one dimension, including clusters of atoms, grains less than 100 nm in size, fibers that are less than 100 nm in diameter, films less than 100 nm in thickness, nanoholes and composites that are combinations of these. They have been used under this technology. So nanomaterials for periodontal drug delivery, that is for example triclosan nanospheres. The future trends mainly on nanomaterials for periodontal tissue engineering and also on nanorobotics. So waiting for a nanodentistry era. So that is the last one, nanotechnology. Coming to the 3D printing, what is 3D printing? It is a term used to describe additive process manufacturing approach that builds material layer by layer. So in dentistry, it has a major role in fabricating stone models, custom impression trays, dental processes, and is also being investigated to provide tissue scaffolding in bone grafting and ridge augmentation procedures in periodontology and implantology. Coming to the artificial intelligence, the future, especially we can tell that the future lies on artificial intelligence. So due to current progress in computational understanding, digitization and data acquisition, use of artificial intelligence is expanding in various fields. Nowadays, AI has become quite popular in the field of medicine and dentistry. That is healthcare as it provides accurate diagnosis and treatment planning of various diseases efficiently. In the field of periodontics, we can say that periosim, it's called as periosim, which is considered as a robotic arm that is widely used in evaluating periodontal pockets by utilizing tactile sensation to differentiate between soft and hard tissues displayed on the visual monitor. Coming to the future advances we are expecting to be in microdentistry is the recently three-dimensional on-screen microsurgery system as an alternative to operating microscope has been discovered, which can now allow the surgeons to view microsurgical field in a wide three-dimensional view in a video monitor. Okay, that's all for today. Thank you.